So hello everyone, my name is Sarah Sims and we're pleased that you could all join us today for a lecture in our volume 5 of our 12-week No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsors for their financial support for the series. Before we start, we want to make sure everyone is aware of our YouTube channel. Every No Neuropsychology and No Neuroanatomy lecture is available for your viewing pleasure. Be sure to check it out, subscribe, and like our lectures. Here are our disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our YouTube channel and the website later this week. Now it's my pleasure to introduce Dr. Yadolakikalis. I don't know if I said that right that time, I'm sorry. For today's lecture on the neurological exam across the lifespan. She graduated from Shiraz University of Medical Sciences in 2014 with honors. During her 7 years of medical school, she completed animal studies evaluating the pathophysiology of memory using scopolamine, and ketamine. She started working as a research fellow at McLean Hospital, Belmont, Massachusetts in 2015. During that time, she completed research on animal models of cocaine addiction and was also involved with Judge Rotenberg Education Center in Canton, Massachusetts, doing neuropsychological evaluations on intellectually disabled patients with severe behavioral problems. She finished her neurology residency in 2021 at the University of Illinois Hospital at Chicago. During her residency, she did research on the cognitive and imaging findings in patients with electrical injury. She started her fellowship at the University of California at San Francisco in 2021. Currently, besides her clinical duties, she's doing research in FDG PET, findings in genetic frontotemporal dementia, and on face networks in patients with semantic variant primary progressive aphasia using fMRI. Welcome, thank you so much for coming, and I'll stop sharing and you can go ahead and get your slides up.
Thank you so much, Sarah.
Yeah.
Okay, you see that wall. Okay, great. So thank you so much for having me today. And today's session is going to be on neurological exam. So I'm going to talk briefly about each part of the neurological exam. So I'm going through them. So the first step in neurological exam is actually to look for any signs on the general physical exam that might be pertinent to the patient's problems. So we don't usually do all of these things that I listed here, but then there are some of them that we always do, and then there are some of them that we do in case we see something suspicious for a disease. So for example, vital signs we always check for patients, but then for orthostatics we don't always check for all the patients. And then we look for signs of a cranial trauma. We always listen for bruise in the carotids, so we use the stethoscope bell, and then we put it on the carotids, and then we see if we hear any bruise, and that's suggestive of a atherosclerotic plaque in the carotids, let's say. And that definitely puts the patient at risk of having strokes. And we always do cardiac exam, we listen for murmurs, we listen for irregular heartbeats, and sometimes we actually find like if patient has is in AFib. And meningismus is another sign that we check if we think the patient has meningitis. So one would be just to ask the patient to bend their head, to try to touch their chest with their chin, and then in case they have a neck stiffness, they won't be able to do that, and that will be a sign of meningitis. Straight leg raising test is another test that we do in case we're thinking patient has spinal stenosis. So we ask the patient to raise, for example, the right leg up, and then in case the patient has this nerve root injury, or there is a pressure or disc herniation putting pressure on an L5 nerve root, when they're trying to raise the leg up, they feel this radicular pain shooting down the right leg. Rectal tone, we check it in patients with called equina syndrome. They might have a urinary or bowel incontinence, and then they have saline anesthesia. And then in that case, we check for rectal tone, but this is not something that we do for all the patients. And dermatological exam is actually another test that we do in patients with neurodermatological disorders. But that, I mean, for example, something like neurofibromatosis, where you see a neurofibromas on the patient's skin. And then in that case, we usually check for other features of neurofibromatosis. Let's say like another disorder will be seeing Chagrin's patch in patients with tuberous sclerosis. So those are the patients who have both neurological symptoms and dermatological problems. So there are 6 elements to the neurological exam, and these are not just the elements, but then there are also the steps that we have to follow when we are doing a neurological exam. So we start with mental status, then we do cranial nerves, motor exam, reflexes, sensory exam, and coordination and gait. The reason why it's important to do them in order is because if someone is not alert enough or someone is not paying enough attention, so then obviously that will affect the rest of the exam. And then you have to modify your exam to be able to test, for example, for their weakness or test for their reflexes. So they might have hard time following the instructions. So that's why it's very important to do them in order. So these are the different parts of the mental status exam. So we check for the level of alertness, attention, and cooperation. Orientation is just asking, I'm not going into details of some of them because I know you're all a neuropsychologist, so you're familiar with most of them. But then orientation is very important to document and also to ask all the way, for example, let's say for time to date, let's say, and then see if the patient knows that, because there's a difference between a patient who knows year, month, and date, as opposed to someone who just knows the year. And memory, if we don't have neuropsychological evaluation at bedside, so to test for memory, sometimes just asking about their social history will be a great help. So then they can tell you what happened, like 2 days ago, what happened like 30 years ago. And language, I'll talk about that later in more detail. Then we can test for calculation, right-left confusion, and finger agnosia if they know the names of the finger, and agraphia by asking them to write something. For right-left confusion, it's very interesting because when you're testing the patients, so for example, you ask them to lift their right arm up or left leg up, so they sometimes feel confused or look confused. So then that will be a sign telling you that the patient has right-left confusion. So you don't necessarily have to exactly test for it. You can just see it while you're doing the rest of the neurological exam. Apraxia is another element that we check for, and neglect and constructions. And by construction, I mean a visual spatial function. And we test for Luria, and I'll show a video of that. And logic and abstraction, delusions and hallucinations, we always ask for. And then sometimes when patients are psychotic, let's say, so it's very difficult to test for that. You can hear it during their conversation, or you can ask their family members. And then mood, we always ask for. So for language, there are different parts to it. So the first will be the spontaneous speech. Just by listening to the patient, you can tell if the patient's speech is fluent, if there's a normal tone to their speech, if they make any paraphasic errors, if they're making up words, or if there's any error in their grammar. So sometimes it's difficult to tell when if you don't listen for it, you might not pick it up. So that's why we always, if there's a suspicion that the patient has a language problem, we send them for speech evaluation. And comprehension, so simple commands, just like, for example, asking the patient to close their eyes, or for example, to smile for you. So anything axial, meaning in the midline, for example, asking the patient to open their eyes, close their eyes, smile. So midline commands are usually easier than appendicular commands, like asking the patient, for example, to tap their fingers. So sometimes if the patient can still follow simple commands, you can do the whole neurological exam without any difficulty. But it's very important to know that, because if patient has any problems following commands, or like simple commands, or even like more complex commands, sometimes you need to break it down. So say, do this and then do this after. So you can't just like tell them the whole thing back to back, because they might not be able to follow, but then you might find abnormality on your exam, but this is not because patient, for example, can't sense something. It's just because they can't follow your commands. And naming is another test that we do as part of a language test evaluation, repetition and reading and writing. So I put up here 2 videos. So one is Wernicke's aphasia and Broca's aphasia is the other. So the difference between those, we usually see them in the setting of strokes. Wernicke's aphasia is when patients have problems understanding you. So this is another term for it is receptive aphasia, where patients have problems understanding, but they don't have any problems expressing themselves, as opposed to Broca's aphasia, when patients have problems expressing themselves, but then understanding, they can totally understand you.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talk with the people for them over there.
So listening to him, she asked a question, but he did not answer that question at all. But then his speech is totally fluent. So this is Wernicke's aphasia. I didn't go through the whole video for the sake of time. And this is a patient with Broca's aphasia.
Can you tell us your name?
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago.
Okay.
And
what did you used to do?
Worked Autodesk.
So the patient understood the question well. It's just he has problems expressing himself, and he makes some grammatical errors as well when talking, but then his comprehension is intact. The other element that we usually check for is apraxia. And the term apraxia means inability to follow a motor command when this inability is not due to a primary motor deficit or a language impairment. What that means is that the patient cannot follow a command, but that's not because the patient is weak in one arm, or it's not because the patient is aphasic and not understanding what you're telling them. It's just because of a higher cortical function where they can't put actions together in order to be able to perform a task. So we have different forms of it. We have ideomotor, we have orobuccal, we have constructional, ocular, and dressing apraxia. And here you see, for example, a patient was asked to blow a kiss, and you're checking for 2 things, one ideomotor and then the orobuccal. Apraxia, the other.
I want you now to pretend like you're opening a door with a key, and pretend like you are cutting with scissors.
And these are all tests to check for ideomotor apraxia. And then, for example, for dressing apraxia, you sometimes even the patients will tell you, or the family members will tell you, for example, they have a hard time putting their shirt on. And the other test or parts of the neurological exam is to check for neglect. We have different types of neglect. We have visual, we have sensory, and we have motor neglect. And here I'll show you the video of both visual and sensory neglect, but then it's important to check for that. And that's because sometimes people who can't, for example, lift an arm or lift a leg is not because of weakness, it's just because they're neglecting one side of the body.
Moving now, and now. How about now? Touching now, and now. How about now?
What he's doing here is touching, for example, one hand, right hand first, then left hand next, and then touch both at the same time. So patients who have sensory neglect, when you touch both hands at the same time, they won't be able to tell that both hands are touched. So they will just lift the right side. Usually neglect is because of the right hemisphere problem. So usually they're neglecting the left side. The right side is usually fine. And then the visual neglect is the same concept. So the patient will be shown like one finger on the right and one finger wiggling on the left, and then both at the same time. And then they should be able to tell whether both, like they see the fingers wiggling at both sides at the same time. So this is a visual and sensory neglect, but then there is also motor neglect. So if they're neglecting the left side, so they won't be able to lift the arm or a leg, but just because they're neglecting, not because of any weakness.
Moving now.
And this is a Luria sequence. I'm sure you're familiar with that, but then just a sequence that we go through.
Wrist, edge, palm.
So you just ask the patient to do that as quickly as possible. Usually we ask them to do 4 in 10 seconds, and then we count, see if the patient can do it in the same sequence. So the next part in neurological exam is cranial nerves. So testing for cranial nerves is very, very important. The reason for that is because, as you see in this picture, cranial nerves come off the brainstem. So if you see any abnormality in the cranial nerves, that tells you there is dysfunction in the brainstem. So there are many medical conditions that can cause lethargy, unsteadiness, headaches, or dizziness. But then if they are accompanied by a cranial nerve problem, that tells you there is a brainstem dysfunction, and that can also help you localizing the lesion. Like, for example, you can say that patient might have a lesion in the medulla, or they might have a lesion in the pons. So that is this part of neurological exam is very, very important, because like, as you know, brainstem dysfunction can be lethal or like fatal. So that's very important to know if there is a cranial nerve abnormality and if there is a brainstem dysfunction. So the first cranial nerve is cranial nerve 1. We usually don't test for that unless there is a specific pathology. Let's say, for example, if the patient has a subfrontal brain tumor, or they're complaining of anosmia, which is what we usually see in the setting of, for example, let's say Parkinson's disease. And what you can do is just ask the patient to smell coffee or soap. The important part of the exam is that to make sure that the patient close one nostril before checking for their sense of smell, because obviously if one nostril is closed and the other one is open, so then they can smell it fine, but then you can't tell if there's a problem. So that's very important to check one nostril at a time. And the other important thing to make sure that you consider when you're checking the olfactory nerve is not to test with noxious odors. So the noxious odors will stimulate the pain fibers from cranial nerve 5. So instead of checking the olfactory nerve, you're actually checking the trigeminal nerve. So that's why it's very, very important to not check the sense of smell with noxious odors. So coffee and soap will be the best options, or mint sometimes. So here.
Can you please cover the right side of your nose, your right nostril?
Here.
Close your eyes and tell me what you smell.
This is how you test for it. The second cranial nerve is optic nerve, and it's very important to use an ophthalmoscope to check the back of the eyes. And we check for the retinas, we check for optic nerve, especially if patients have any complaint about, let's say, visual loss, double vision, loss of color vision. So that's very, very important for part of the neurological exam and ophthalmoscopy exam. And visual acuity, we usually check with Snellen chart. So you show the patient the Snellen chart, and then you ask them to tell which, like sometimes there are numbers, so then they just need to read off the numbers, but you need to check one eye at a time. And then color vision, so this is Ishihara card. So you show them the card, so there is a number on the background of some colors. If they are able to tell the colors apart, they should be able to tell the number. But then people who have problems with color vision, they can't do that. There is another test that we check in patients, usually with optic nerve problem. We commonly see it in optic neuritis in the setting of multiple sclerosis. So they have red desaturation. There is an easy way to test for it. I have a video of that, but then you just show them a red object, have them close one eye, show them a red object, and then switch eyes and see if they see the red as sharp as they saw it with the first eye. And if there is any dullness in the color red in one eye, so that tells you there is red desaturation. And visual fields, it's easier to watch it on the video, but then you just stand in front of the patient and then ask them to look straight at you. They should not turn their eyes to one side or the other, and then you ask them to tell you how many fingers you're showing them. And in comatose or uncooperative patient, the alternative to that is blink to threat. So let's look at some videos. So this is a blink to threat. So you bring your hand from the sides, don't bring it in like towards the patient, because then obviously the patient will be able to see it. So it should be from the sides and see if the patient will blink. So this is usually done in a setting of coma or unconscious patients. So in alert patients, we don't usually do that test. We check for visual fields. So
Look right at my nose, and I'm going to check your visual fields, okay? I want you to tell me how many fingers you see in each hand.
1, 1, and 1.
They have to look straight at you and look at your nose, not look at your fingers. And this is an ophthalmoscope.
To view the fundus, an ophthalmoscope is used, and the patient is asked to look straight ahead while the eye is approached at an angle of approximately 15 degrees. Please look straight ahead.
And this is what we see. So this is optic disc, and these are the vessels. So if you see, if you can see the optics very well, so that tells you there's a problem in the optic nerve. And this is red desaturation.
Can you cover your right eye, please? What color is this?
Red.
Cover your other eye, please.
So they are just showing the color and like a red object, and they should be able to tell if it's red, and the sharpness in the red changes as they switch eyes. So the next part in the optic nerve is pupillary reflex. So first, you just look at the patient and look at the size of the pupils, look at their shapes, if there is any asymmetry in the size, and then you check for the direct response. So you shine the light into the eye and see if pupil constricts, and then you look for the constriction of the other pupil, because we expect if you shine the light into the right pupil, the left pupil constricts as well. So this is a direct response in the right eye and concentric response in the left eye. And you also test the pupillary response to accommodation. So you bring your finger close to their nose, and then they should accommodate, and also the pupils should constrict. So you're checking for both. And then there is this thing called HIPS, where the pupil size fluctuates. So it gets smaller, it gets bigger. So very small fluctuation in the pupillary size is normal. So it's not suggestive of any sort of pupillary abnormalities. So here is pupil accommodation.
Can you look at my finger, please? And observe the pupils as the fingers move towards the eye.
And
look straight ahead, please. To test pupillary responses, shine the flashlight on each eye and measure the diameter of the pupil in millimeters, noting also its shape in the eye the light is flashed into, as well as the...
So you shine the light and you see the constriction in the pupil, but then at the same time, you need to see the constriction on the other side as well, which is the concentric response. So extraocular movements are done or performed by 3 cranial nerves. So it's 3, 4, and 6. So basically by checking extraocular movements, you're checking for all these 3 cranial nerves. So you just observe the eyes at rest, see if you see any abnormalities, like if you see any spontaneous nystagmus or disconjugate gaze. And then you ask the patient to look in all directions and without moving their head. And you test for smooth pursuit, and then you also test for saccades. So smooth pursuit is just like move your finger very slowly in front of their eyes. It should be 1 second in each direction, so you shouldn't move your finger right and left very quickly. And for saccades, it's easier to watch the video. And then convergence movement is the same concept as accommodation. So you bring your finger towards their nose, and then the eyes should converge. So this is the horizontal pursuit.
Please look at my fingers and follow them with your eyes.
See, it should be slow. It should not be fast from one side or the other. And then you check for the pursuit in the eye movements. And then this is the saccades.
Look right at me. And now I want you to look at my thumb without moving your head. Look at my finger, back at my thumb. Without moving your head, look at my finger, thumb, finger, thumb, finger, thumb. Good.
And you check it vertically as well. The next cranial nerve is cranial nerve 5. There are two branches in cranial nerve 5. One is sensory branch and the other is a motor branch. So the sensory branch is gives sensation to the face, and you see the distribution of the sensory branch of cranial nerve 5. So it goes all the way to the back of the scalp. So and that's why, for example, if some patients complain about numbness on the top of the head, that could still be cranial nerve 5. And you also test for corneal reflex, where I have a video of that. You touch the cornea with a cotton wisp, and then the patient will blink. The part where you're touching the cornea is cranial nerve 5. That's the sensory part, and where when the patient blinks is cranial nerve 7. And for the motor part of the trigeminal 5, it gives innervation to the jaw muscles. So that's to test for that, you ask the patient to clench their jaw, and then you basically palpate the muscles to see if they are stiff. And there's this jaw jerk reflex that's mediated by cranial nerve 5. And I have a video of it, but then basically what we ask the patient to do is to open their mouth slightly, and you tap on their chin, and you see the jaw closes. And that's both the afferent and the efferent pathway are mediated by cranial nerve 5. So this is the jaw jerk reflex.
Open your mouth slightly.
Open their mouth, and then you tap on their jaw with a reflex hammer.
Good.
And you expect, sometimes it's normal, so you see it in normal patient population, but then usually when it exists, it's suggestive of a brainstem abnormality. So that's why it's very important to check for that if there's a suspicion for that. Muscle
Can you
mastication.
please clench your jaw tight like this? Good. And I'm feeling her masseter muscles, and relax.
This is clenching the jaw, checking for the motor part of the motor branch of the cranial nerve 5.
Does this feel the same or different on both sides?
Feels the same.
Okay. How about here and here?
Feels the same.
And here?
So you're checking for different distributions of cranial nerve 5. So you check the ophthalmic branch, you check the maxillary branch, and the mandibular branch. And
the
this
corneal
is the corneal
reflex is tested by having the patient look up and using a cotton-tipped swab.
Blink. So the afferent branch is cranial nerve 5, and when the patient blinks is cranial nerve 7. So the next cranial nerve is cranial nerve 7. The reason why we skipped cranial nerve 6 is because, if you remember, we discussed it in the extraocular movement. So we already checked for that. And cranial nerve 7 is responsible for the muscles in the face. So the way to test for it is to ask the patient to smile, puff out their cheeks, clench their eyes tight, or wrinkle their brow. And you look for any asymmetry in the facial shape, in spontaneous expressions and blinking. And sometimes it's difficult when the patient has facial diplegia. So that's very important if that's the case, so it's very important to check the old photograph. So I had a patient who had Guillain-Barré that involved both sides of the face. So, and the patient was diplegic, so basically could not move both sides. So you could not tell if one side is weaker than the other. The other branch of facial nerve is actually the taste branch. And then we also sometimes test for that if you're suspecting a facial nerve problem, like, for example, someone who has Bell's palsy, then you can check for the taste sensation on both sides of the tongue. So in this picture, you see a patient with a central facial palsy and a peripheral facial palsy, like what we see in Bell's palsy. So in this picture, as you see, a patient cannot move half of the face, top and bottom. But then here, in central facial palsy, the top part is fine. So the patient can raise the eyebrow, but then cannot smile. So that's how you can tell the difference between a central and peripheral facial palsy. Why that is important is because in central facial palsy has a central origin, so it could be because of a stroke. But then the peripheral facial palsy is Bell's palsy because of the problem in the facial nerve coming through the ear. So it's not, both needs to be treated, but then peripheral is not as urgent as the central facial palsy.
Do you know any good jokes?
So we check for the
Okay,
patient's
let me see
smile.
all of your teeth, please. Good. And puff up your cheeks. Good. And close your eyes real tight, and don't let me open them. Close your eyes tight. Very good.
Okay. So the next cranial nerve is vestibulocochlear nerve, or cranial nerve 8. And there, as you can tell by name, so there are two parts to it. So there's a vestibular branch and there's a cochlear branch. The vestibular branch is the branch that helps with the balance, and the cochlear branch is the part where we can it helps with hearing. So to test for the cochlear branch, you just rub your fingers close to their ear, one ear at a time, and then ask the patient if they can hear your fingers. Basically rubbing of your fingers, and then the vestibular sensation is tested just when we're suspecting a vestibular problem. So we don't usually test it in all the patients. Usually when patients are complaining about vertigo, or and they have problems in vertical or horizontal gaze, or for example, if they have nystagmus, then you need to tell if the problem is in the nerve itself or is coming from the nucleus in the brainstem. So in those situations, we usually check for the vestibular sensation. Otherwise, we usually don't test for it. So this is a hearing test.
Close your eyes, please. Tell me which side you hear my fingers rubbing on.
My left.
Right.
This.
And this is a Dix-Hallpike maneuver where we and when we do to test for a peripheral or like BPPV, which is a benign paroxysmal positional vertigo. So when there is a peripheral problem causing vertigo, so we do this maneuver and look for nystagmus.
For positional testing to detect abnormal vestibular function, the patient sits near the edge of the table. The head is turned in one direction with one ear down, and then supporting the head, the patient is asked to rapidly lie back, and eye movements are observed.
And you check to see if there is any nystagmus. Usually there is a lag, so it's not like the patient start having nystagmus the moment you lay them down. So then you have to give them a few minutes, like about 10-15 seconds, seconds, for you to be able to see the nystagmus, if there is any. And if you see the nystagmus, that is suggestive of a problem in the ear causing the vertigo. So the two other cranial nerves are cranial nerve 9 and 10. The job of they do a lot of things in the body, but then the part where we're testing for is the palate elevation. So you ask the patient to say "ah," and then you see if the palate elevates. Sometimes when there is a problem on one side and not the other, so you see one palate elevates and the other doesn't. So you can see it clearly using the tongue blade. And then you check for the patient gag. Usually we don't check gag in case we're suspecting a brainstem, unless you're suspecting a brainstem dysfunction or a patient is unconscious or there is an impaired swallowing. Otherwise, we don't usually check gag because it's not the most comfortable type of test. So this
Open your mouth, please.
Elevation.
Say ah.
Ah.
Very good. Open your mouth.
Good. And then for the muscles of articulation, there are different muscles involved in articulation, and they get their innervation from different branches like cranial nerves. So the muscles of articulation, there are different ways to test for that. Sometimes you ask the patient to say mama, gaga, la la, so you can test for different sounds and structures. For example, if they have problem in their lips, or they have problem in their tongue, or there's a problem in the palate. But then it's very important to test for that, because sometimes you hear slurred speech, but you can't tell if the patient has dysarthria or the patient has aphasia. So that's why it's very important to test it for muscles of articulation to see if the problems in patient's speech is actually dysarthria or an aphasia, because aphasia is a language problem, so it's coming from the cortex. Dysarthria might not necessarily be a problem in the cortex itself. It might be a problem, let's say, in the tongue or in the palate. And then, as I mentioned here, so it's like it could be coming from different regions of the brain, but then it's very, very important to check for it when the patient has a problem in their speech. So here.
Please say pa 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 pa.
So you check to see if there's a problem in the lip.
Ta 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 ta.
Ta 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 ta.
Good. Ga 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 ga.
Ga 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 ga.
And that's the palate. And the previous one was that check to see if abnormality in the tongue. And then here is the test for accessory nerve. So accessory nerve, the job of that is to bring the shoulders up and then turn the head in like one direction or the other, and also flexing the head forward. So that's what cranial nerve 11 is responsible for. So
Please turn your head that way. Don't let me push it back. Good. Please turn your head that way. Don't let me push it back. Good. Please pick up your shoulders like this. Good. And please move your head forward and don't let me push it back.
And the last cranial nerve is cranial nerve 12. And we usually check for atrophy and fasciculation. So you just like have the patient open their mouth and then you look at their tongue on the floor of the mouth, see if you see any quivering movements. Usually we see that in the setting of ALS. And then you ask the patient to stick their tongue out and look to see if you see any deviation in the tongue. And then you ask the patient to move the tongue one side or the other. And the reason why I put this picture here is to show that cortex gives innervation to the nucleus, hypoglossal nucleus, and then that gives out the nerve to the tongue. The reason why this is important is because if there is a problem on one side of the cortex, the opposite side of the tongue will be plegic. So that's why what you see on exam is when the patient sticks their tongue out, so you see the deviation towards the side where there is a cortical lesion. So it deviates through the lesion because let's say this is the tongue and the left side is weak, the right side is strong. So the right side pushes the tongue towards the left side. And this is a test for.
Please stick your tongue straight out. Okay, good.
And then you also ask the patient to move the tongue right and left. The next part of the neurological exam is motor exam. So you always observe to see if you see any fasciculation, especially if the patient has any complaints about that. Or for example, if you're suspecting ALS as a possible diagnosis, then you check the strength and then you check for like the functional testing of the motor exam, and then I'll go through each of them. So motor strength, there are 5 ratings when you check for motor strength. It depends. Most of the times, in case of a stroke, you don't go into details, but then when there is a general physical exam, you always say, for example, a patient was 3 out of 5, like in one limb, and then 4 out of 5 on the opposite one. So 0 means no contraction, like no movement. 1 out of 5 is mild flickering, but there is no movement. So the patient might try to move the hand or the leg, but then you see some flickering, but then you actually don't see any movement. 2 out of 5, the patient can move the limb, but then it's not against the gravity. So it's on the horizontal plane, they can move the leg or the arm. And then 3 out of 5 patients can lift the leg or the arm against the gravity, but then the moment you put some pressure on it, they just like drop the arm or leg. And 4 out of 5, they can resist the examiner to some extent. Then you can divide it to 4 minus, 4 plus, depending on how much resistance they can tolerate. And then 5 out of 5 is full strength. And it's a long video.
Please hold your arms out straight like this. Don't let me bend your fingers. Keep them straight.
You check for all the muscles.
Very good. Keep your fingers together like that. Don't let me pull them apart. Don't let me push your wrists down. Good. Okay, now spread your fingers apart. Very good.
So this is checking for each single muscle in the hand. So especially when patients have any complaints, for example, any weakness in their hands, or for example, if they have carpal tunnel or a radicular pain disc problem, so then you have to check for every single muscle in the hand. But then usually on general neurological exam, we don't test for every single muscle.
Please hold your arms out.
So the next thing that we usually check as part of the motor exam is tone. And there are 2 different tones. So one is spasticity and the other one is rigidity. So spasticity is velocity dependent, meaning that you have the patient relax and then you suddenly open their arms. And there is this like resistance when you're doing that, and it's a class like, meaning that if you do it fast enough at the beginning, you might feel a catch and then it releases. So that's spasticity. And it's suggestive. It usually happens after stroke, or it can happen like in ALS or other disorders as well. But then the most common scenario where you see spasticity is in the setting of a stroke. And the key to this testing is the velocity of it. So if you do it very slowly, you might not feel it. So it should be a fast type movement. And rigidity is resistance, but in all like at all velocities. So the rigidity is not velocity dependent. So like when you like move the hand or like the leg around, so you feel this rigidity in all directions at all velocities. And that's called the lead pipe rigidity. And what you see in the setting of Parkinson's disease, there is this cogwheel rigidity that you might hear a lot. That is also rigidity. The difference is that the patient also has tremor. So when there is tremor and rigidity, that is when it's called cogwheel rigidity. So it's basically, again, rigidity. It's not something different from that. It's just because the patient also has a resting tremor, let's say on the top, or like even like action tremor, you might feel the cogwheel rigidity.
Very good. Tone of the legs can be tested by asking the patient to please relax, and then suddenly bending the knee.
So you should see the foot dragging on the table. So if the foot lifts up, so that tells you there is an increased tone in the leg. So it should drag on the table when you're checking for the leg tone.
Very good.
And the functional testing, so we check for two different things. So one is bradykinesia. So you ask the patient to tap their fingers, and you ask them to tap as fast as they can. And they turn their hands, and then also open and close your fist. So for the bradykinesia, what you're checking or looking for is to see if there is any decrease in the amplitude. So when they start tapping, they might first start big and they go small at the end. So that is bradykinesia. So it's also the slowness of the movement, but what we are actually looking for is the amplitude of the movements as well. And what you see in this picture is drift. So you ask the patient to close their eyes and then hold their hands in front of them. And then you see if there is a drift. So one hand goes down. So that is what you check for. And if one hand goes down slowly, that tells you that hand is weak. So the patient cannot keep it up for, like, let's say 10 seconds. And that is suggestive of any weakness, but then we also check it in the setting of a stroke. So here.
Just like that. Very good. Can you take your right hand and pretend you're screwing the light bulb as fast as you can, please? Good.
That's the test for bradykinesia.
Just like that.
And then tremor. So we have two different types of tremor. We have action and we have resting tremor. Action tremor is what you see commonly in practice. So postural tremor, when patients like try to do something, for example, you ask them to hold their arms in front of you, just in a relaxed position, and then you see some tremor in the hand. That could be physiologic, so it doesn't necessarily point to a pathology. But then resting tremor is definitely a pathology. So if you see a resting tremor, it's like almost always points to a extrapyramidal disorder like Parkinson's disease, Lewy body disease, where you see it commonly. And there is this tremor called intention tremor. It's also an action tremor, but then you see it in the setting of a cerebellar problem. So when the patient you ask the patient to do finger nose testing, and then by the time they get close to your finger, they start having this tremor. So that's an intention tremor, but that's also an action tremor. And the difference between an intention tremor and a postural tremor is that when someone has postural tremor, they have the tremor. For example, when they go from their nose to your finger, they just have this tremor all the way through. But then intention tremor, they are fine, but then they start having the tremor as they get closer to your finger. And astriasis is what you see in this video. So you ask the patient to hold their wrist back in an outstretched way, and then you see astriasis, so this like flapping type movement, and you see it in the setting of metabolic disorder, like let's say someone has hepatic encephalopathy or a kidney problem. That's when you see astriasis. And in reflexes, we have 5 rating for reflexes. So 0 means absent, and 1+ means trace. Normal is 2+. Brisk is just like sometimes when people are anxious, you see brisk reflexes. So the moment you tap on the knee, they just jump, but that doesn't mean that it's abnormal. It's just they might be anxious. So brisk might point to an abnormality, but then not. It could also be physiologic. And definitely non-sustained clonus is what you see in this video.
Neuron cannot inhibit the lower motor neuron.
So you see this clonus in the
neuron cannot inhibit
So
the
it
lower
just
motor neuron.
keeps having this vibratory type movements. And then sustained clonus. So non-sustained means that they have 1 or 2 beats and they stop. And then sustained clonus is what you see in this video, where the patient like keeps having clonus.
Neuron.
And then the reflexes, we check for biceps, tricep brachioradialis, patellar, Achilles, and a plantar reflex. And this is a plantar reflex, so you just scratch the bottom of the foot, and then you see if the toes curl, and then you see it in this picture as well. The normal is the one that you see on the left, and then the abnormal is the right side, so then the fanning of the toes, and then the here that's abnormal, and that's suggestive of a upper motor neuron problem, so a problem in the spinal cord or a problem in the brain. And this is Hoffman, so you flicker the middle finger and then you look for thumb adduction and also flexion. And there is also a cross adduction reflex where you tap on the medial side of the knee, and then you see if the knees adduct. And that's also suggestive of an upper motor neuron problem. That's hyperreflexia. So if you see it on both sides, it might be normal, but then if you see it on one side and not the other, that will be a sign of an upper motor neuron problem. So these are different reflexes that we usually check for.
Brachioradialis.
When you're testing for reflexes, the important thing to make sure that you follow is to just hold the hammer loose. So then in case like you just use it like as an actual hammer, you won't be able to get a reflex. And then we have frontal release signs. So we have palamental reflex, we have grasp reflex, we have glabellar reflex, where you tap on the forehead and then you ask the patient not to blink. If they keep blinking and they cannot inhibit their blinking, that tells you there is a problem, like an upper motor neuron problem, or there is a frontal release sign, meaning there is a frontal atrophy. And then snap reflex is what you see on this picture. So in this video.
Good.
So they should not like try to basically kiss that cotton wisp. So that's a snout reflex. And if they have it, that's also a problem. And palamental reflex, you just scratch the palm of the hand and then you check for any sort of flexion in their chin. The next part is sensory exam. We check it with different modalities. So we do light touch. So you just use your hand or a Q-tip to check for their like sense of light touch. And then pain, you can use a safety pin to check for pain and then see if there is any difference from as you go up. So you start from, let's say, foot, and then you go up and ask the patient if you feel it more as you go up. And then if they say no, for example, the sensation is the same on the foot and on the knee, so there is no length-dependent sensory loss. But then if they feel it more as you go up, that tells you there is a length-dependent sensory loss suggestive of a neuropathy, like a peripheral neuropathy. Same with the hands and arms. And temperature sensation, vibration, and then proprioception are the other modalities that we usually check for. So
Using a new safety pin for each patient. Does this feel the same or different on the two sides?
and then you compare size as
same.
well.
Okay, and how about here and
Sharp. Dull.
temperature sensation can be tested with a metal. Tell me if
Then
this
you can
feels
use
cold or warm.
you can also use your tuning fork to check for the temperature, because usually the tuning fork is a metal, so it's usually cold. So that's what we usually use to test for temperature sensation.
Very good. How about now?
And then you hold the tuning fork. You first try to make it vibrate, and then you put it on the toe, and then you ask the patient when they can't feel the vibration anymore. But then sometimes the patient tells you they can't feel it anymore, but you're still feeling it holding the tuning fork. So that means that they have decreased sense of vibration.
How about now?
No.
How about now?
So by holding the tuning fork, actually the examiner stops the vibration. So then if the patient tells you, oh, I can still feel it, so that's like suggestive of a functional problem. So they should not be able to feel it anymore when basically it's not vibrating.
No.
Very good.
And this is
Testing
the
joint
joint.
position sense in the normal individual requires only subtle movements, barely visible to the eye. Grasp the patient's digit by the sides so as not to provide tactile cues. Please tell me whether I move your finger up or down. Close your eyes, please.
Down.
See, very small movement. You bring the finger down a little bit and then up a little bit. And you should not hold it like this. So it should be on from the sides, and then you bring it up and bring it down a little bit and see if they can tell which way you're moving it. And you have to give them the instruction at the beginning that it's either up or down. So sometimes people tell you it's on like to the side. So you should instruct them that it's either up or down. And should be very subtle. So obviously, if you move the finger all the way up, they can tell. But then the reason why we do slight movement is because to check for any cellular neuropathy.
Using a new safe.
And this is cortical sensory function. So we have a graphesthesia, meaning you write something on the palm of their hand, for example, a number or a letter, and then ask them to say which number it was or which letter it was. And obviously it has to be with the eyes closed. And stereognosis is you just give them an object, for example, let's say a safety pin, and then you ask them to touch it with one hand and see if they can tell what the object is, but you're just using one hand. It should not be both hands. So, and like it could be a pen, it could be a safety pin.
I'm just letting you know that we're at 12:51.
Great. So it should be done in 5 minutes. So coordination is finger nose testing. So we talked about it in intentional to check for intentional tremor and dysmetria. And then we have this diadokinesis. So then you ask the patient to flap their hands. And then Hill-Tushin test is also a test of coordination. It's very important to know that these are the tests to check for any cerebellar dysfunction. And then if the patient is weak or they can't sense something, or like, for example, they have decreased sensation, these tests might not be reliable. We can skip the videos.
With the back of your hand.
And then gait. So we have different types of gait or abnormalities in the gait, but then usually when you ask the patient to walk, you check for their posture, you check for their arm swing, step size, width of base, and an ability to walk on toes or heels. We have different gait abnormalities. Could be in a taxi gait where they can't do the tandem walk, where you ask the patient, is like a drunk test. So then you ask the patient to put one foot in front of the other and see if they can do that. Wide base gait is suggestive of a problem in the dorsal column in the spinal cord. Shuffling gait is what you see in the setting of Parkinson's disease, where people like shuffle, they're getting drag their feet on the floor when walking. Fascinating gait is another term that we use for fascinating gait is magnetic gait. And when the patient stands up and they start to walk, they feel like their feet are stuck to the ground and they have to like give themselves a push to be able to move. And that's suggestive of a frontal lobe problem, or we can see it in normal pressure hydrocephalus. And the Romberg test is when you ask the patient to put their feet together and then close their eyes and then see if you see any swaying in their body. The positive test is when they can't do that, they just lose their balance. And then in cerebellar dysfunction, patients have problem both with their eyes open and closed.
Each other.
And these are different types of gait abnormalities. So seizure gait is what you see in the setting of a spasticity, for example, after a stroke. Same with spastic gait. And steppage gait is when there's a foot drop. So every time they lift the foot, it just like drops on the floor. And waddling gait is usually the reason why they put a picture of a child here is because you see it in the myopathies, which is a childhood problem. And then propulsive gait is what you see in the setting of Parkinson's disease. And I just put this here. I don't think I'll go through this. So this is like signs suggestive of a functional neurological disorder. But I think we can skip that. And that should be it. I'm happy to take any questions.
Yes, thank you so much. Actually, if you want to go back one slide, the first question is actually about neurological exams being determined as functional. What factors are considered, and are there any quantifiable ways to determine whether an exam is functional? So it's actually very good timing.
Sounds perfect. Great. So I can actually talk about it. So there are different tests that we usually do to check if the patient is functional. One would be hand dropping test. That means that when the patient is, let's say a patient is in coma, or you think that a patient cannot follow any commands, what you can actually do is to lift let's say one arm up, and then you try to like let it go, but then over their face. So if the patient is functional, they try to avoid their face. So when you do that, they just like bring their hand to the side and then put it down. But then obviously if the patient is in coma, it doesn't matter like where you leave the hand, they just like might drop it on their face, they might drop it on their chest. So that's one test. The other would be saccade eye movement. So saccades would not be present in coma. So if someone, let's say, is complaining of like not being able to see, something like that. And then you can check for optic kinetic nystagmus. So these are these stripes that there are different colors, like it's white, black. And then you just move it in front of the patient. In normal patient, they just like go from white, they have these saccade eye movements because they can actually see. But then if patient is in coma, they just don't see anything. So then it's because they're in coma, so then they can't do that. And variable resistance, so that's when you check for tone and you like one time they are good, like they are loose, and then again they become resistant. So then that's another test. And I'll talk about Hoover test in a second. And the midline changing vibration sense is actually one test that could be easily done. So you use the tuning fork, and then you when it starts vibrating, you put it on the forehead. If patient is functional, they say, oh, I feel it more on the right, or I feel it more on the left, something like that. But then it should not be the case because the vibration goes through the bone. So they should feel it the same on both sides. And then sometimes when people are, they complain about weakness, but then when they're sleeping, you see some movements. For example, they start moving their leg or they start moving their arm. So that's also such as functional disorder. And then Hoover test is, the way it's done is, for example, let's say patient is weak on the right leg, and then you put your hand underneath the left ankle, and then you ask the patient to lift the right leg, which is weak. So when patient tries to do that, they have, because they are weak, so they try to push themselves to do that. So then they actually put some pressure on the left heel. So then you feel the pressure on your hand, which is underneath the left leg. But then when the patient is functional, they actually make no such effort. So then you don't feel that pressure beneath the left leg. So that's a Hoover test that tells you that the right leg is not actually weak. Hopefully that answered your question.
Yeah, that was great. And it was great. You already had the slide ready to go. Good timing. So I noticed that you got a lot of your videos and things from the book, but I was wondering if there were any useful tips for people like us who, don't do the full exams every day, but we may read reports from them and stuff like that. But we may want to do a little bit when a patient is in front of us, say they haven't seen a neurologist or something like that.
Mm-hmm.
So do you have any like good cheat sheets or kind of like here's some good high points to hit?
Sure. I think the main things that we need to do from each of those elements, I think first would be definitely mental status exam, just orientation. I don't think we need to go into details of everything else because you can just tell by listening to the patient if there is, let's say, a problem with language. Cranial nerves, I think the important parts will be just like to check for eye movements, I would say. And then we always check like patient to give us a smile. So that should be quick as well. And then for the motor part, it will be just the gross motor exam. So like ask the patient to lift the arms up and then check like, for example, for the shoulder, like weakness or anything. And then same with the legs. And then reflexes. I mean, it's difficult sometimes to test for, especially like if the hammer technique is not correct. And tone, it's not that important if there is no suggestion of for example, let's say Parkinson's disease or a stroke. And then if coordination, it's easy. We can just like do finger, nose, finger, and then the gait, just ask the patient to walk. So I think those are the main elements. Just by doing that, which are the things that we actually do over Zoom as well. So would be informative enough to say if there is an abnormality.
I am kind of curious of ones that you do ever do. How do you test strength over Zoom?
Oh, the strength, usually we do the drift. So we ask the patient to lift the arm up and then hold in front of the camera and then close your eyes. And then if we see any sort of like downward shifting, so that tells us there is a problem with strength. But then obviously you can't tell exactly like if the patient is like 5 out of 5 or 4 out of 5, let's say.
Yeah, I was just curious because I was like, Zoom, strength, how's that go together? But that's really great. It seems like you have to be creative with telemedicine. But thank you for hitting the highlights. That's a good like kind of mental checklist to do really quickly at the beginning of an exam. So thank you so much. That was all the questions that we have for today. We're almost out of time as well. So we will be having another lecture next week. Let's see the time. It's at 3 p.m. on the 16th, 3 p.m. Eastern time. And it's feedback 360, culturally competent neuropsychological feedback across the lifespan. So thank you everyone for joining us today. And we'll see you again next week.
Thank you so
Thank
much.
you so much. Have a good day.